Well, welcome to week 13. Today we will be discussing and looking at a lot of pictures of dental implants. So in this first slide, I would like you to ask the question or ask yourself, what do these things have in common? A dental implant, a Porsche, a baby, and the character of Meg Ryan from the movie When Harry Met Sally. So just think about what these things have in common. We're going to watch a video from the movie here in a second, and at the end we'll answer the question. Today in America, over 3 million Americans have dental implants, and they've obviously gained popularity throughout the years. Some rough statistics show that 60% of people quit wearing their dentures after 3 years, and only 35% keep wearing them after 10 years. I think it's just the dentures that aren't fixed. They are easy to take out, and you can get in the habit of not wearing them. Dentures, from what I hear from patients, they aren't comfortable. They don't wear like real teeth. So a lot of people are going to the use of implants to hold partials or to replace single teeth or to hold, a denture in place. So in practice, you're going to come across implants. So today we're going to talk about different types of implants that are placed and how to take care of them and how to check to see if they're healthy or if they're in a disease state. This picture is showing you a implant setup. It appears that there are 4 implants placed in the lower mandible, and it's to hold in a whole lower mandibular arch of dentures. If you see down here at the bottom, right here, that fits right on top of the arch, and it is removable, so they can take that off and clean underneath this particular type of implant setup. So again, we're going to just keep looking at different types of implants, and you might come encounter with in your practice. Okay, this example is showing us that we have 2 implants placed in the lower right mandibular arch, and then on the lower right hand side of the screen you can see that they have placed the crown and the Pontic over the implant fixtures, and this is the Pontic right here. And that's where you would want to focus on cleaning as well. When you're treating patients like this, we're going to talk about how to clean an implant shortly. But just know that that is your Pontic with a fixed crown bridge. Okay, so let's talk a little bit about the history of implants. Under week 13 in BB-Learn, you'll find an article that I've attached. It's kind of a fun perspective of dental implants, so just kind of go over there and check that out after the lecture. It really kind of goes into more detail, but I'll kind of give you a brief overview. But that picture in the upper right hand corner, that's a real picture, and we're going to talk a little bit about that in a second. But what they were finding and what we found is that in about 2500 BC, Egyptians tried to stabilize their teeth using wire made of gold. And then around 500 BC, it was founded that humans were utilizing ox teeth. So they were using animal teeth as a replacement for teeth. And then in about 300 AD, evidence was found that humans were using ivory with gold wire to create the fixed bridge that you see in this picture right here. The first proof of a dental implant being placed was found from the Mayan culture, and it was around 600 AD. And the reason why we know that is that they have radiographed Mayan mandibles that had been found in the 1970s. And what they found that Mayans used shell to replace teeth with, And the interesting finding was around the implanted shell into the mandible, compact bone formation was growing around the crude implants. So, you know, people have been using implants or some type of restorative correction since the beginning of time. I guess we've always cared about what our teeth look like. So in the mid-20th century, of course, they started trying to figure out how to do this properly, and that's when the notion of fibro-osseous integration took place. And fibro-osseous integration, what they were trying to mimic the PDL. So dentists were integrating basically collagen fibers in between the bone and the fixture itself. They weren't focusing on sturdy bone growth. They thought they needed that PDL-like action of like shock absorption, if you will. And they were also using materials that weren't compatible to the body. They were using stainless steel and cobalt. So what was happening is these doctors were placing these implants that were not compatible with the body, using material that wasn't successful. The body was pushing out the fixture. The body is recognizing it as not self, and it's going there with the inflammatory response, and it was just kind of kicking it out, making it not stable. There was mobility, didn't work. So Dr. Brainmark in the early 1980s, he discovered that titanium was a biocompatible element that the body didn't recognize, therefore it didn't try to push it out. And I do have a really good short video under week 13 as well, where a doctor is explaining, you know, the purpose of osseointegration and titanium. And osseointegration now is the gold standard for dental implant success. And basically, they're just utilizing bone grafting, bone integration, bone surrounding the implant fixture, keeps it stable, keeps it sturdy. And they're proven to have a 10-year success rate, if not more now, with technology and the way that we handle dental medicine now. Okay, we're going to talk about 3 types of dental implants: subperiosteal implants, transosteal implants, and endoosseous implants. These first 2 types that we're going to discuss, subperiosteal and transosteal, they're not used as often anymore, and very rarely will you come across patients that have dental implants like this. The subperiosteal, I want you to think about the implant. It's a custom cast frame, if you can see in the middle picture there, that's made to rest on top of the bone, and you have to cut the gum tissue open, and it sits and it covers on top of the mandible. It's used more for people that don't have enough bone to tolerate endoosseous or unable to wear conventional dentures. That's when you will see somebody that's using a subperiosteal. Really, the only thing that you need to know about that one is that it exists. So if you take a pano and you happen to see those wire fittings that place down right over the bone, that you know that that's what type of implant it is, and just think that it's sitting on the bone. Transosteal implants, this one, boy, this one requires hospitalization. They cut into the mandible, they go up and through the jaw. It's limited only to the mandible. The rods, if you look at the x-ray, the pano down at the bottom of the screen, the rods are protruding through the chin, and then the implants go in and set on top of those 2 wire rods there. And the thing that I like to point out in this picture is, look how thin the jawbone is right here. And sorry, my drawing is not so great, but that's a really thin piece of bone right there. And so endoosseous implants, this patient probably wouldn't be a good candidate for an endoosseous implant just because of the thinning of that mandible. So the third type of implant that we're going to discuss is the endosseous implants. And these are the most common type of implants used on the market today. These are the most common ones that you'll be seeing with your patients or in your radiographs. But if you'll notice the different types of fixtures, these are called fixtures. You'll also, your book also refers to them as the body of the implant. You're going to hear it interchangeably. I believe you'll hear fixture more than body, but they're all four on this page. They're all endoosseous implants, no matter what they look like. And just think of the endoosseous implant as the root replacement. So that's that fixture part, the screw part that actually is embedded into the bone. That is the root replacement. So this is the stabilizer that's going to hold the prosthesis, the crown on top. And it doesn't matter what they look like. They're all there's different manufacturers. Usually I pass these around and you guys get to play with the different types of implants. Again, I apologize. I think the most common one that I see is the one in the middle, the third one over. This is the one, it looks just more like your regular screw, this one, or this one I see a lot. But the holes that you see in the fixture itself, that's just more open space for the bone to start kind of growing in between to kind of help stabilize. The one that kind of looks threaded, the bone is going to kind of grow in those threads as well and around everything. So that's part of the osseointegration. So the part of the implant embedded into the bone is the fixture. And again, you might also hear this referred to as the body. But remember, it's the root replacement. It's the fixture. Okay, you definitely want to memorize the different parts of the implant itself when we're talking about the endoosseous implant, the most common. And you want to know where the fixture is, which is the root replacement. And then you want to know about the abutment. And the abutment sits on top of the root replacement, the fixture. So those on this slide right here, you want to know that there's a fixture and there is an abutment. Well, along with your fixture and your abutment, there's also the prosthesis. And just note that the prosthesis is the crown. So fixture, abutment, prosthesis. You need to know the parts of the endoosseous implant. In this graphic, it's just depicting that when you place the prosthesis on top of the abutment, there are just the screws that hold it in place. And those screws are just what are holding the crown into place. This slide is just showing you that there's different sizes and shapes of fixtures and abutments depending upon the patient's needs and the location in the mouth, the angle that is needed for the crown to set in the dentition. So in order for osseointegration to take place and the fixture being held into place with that bone, you have to prep the sites and you have to have a compatible material, which is the titanium. And then, the surface property of the fixture itself must be compatible. The hydroxyapatite, that's the bone, that's the graphene surface. And when it talks about the amount and the quality of bone, that is that bone height and that mandible, like I discussed in that picture with the transosteal implant, where it seemed like the mandible was very low in height. And you want to have a certain amount of bone height, quality, and quantity to make a difference for the fixture to be successful. When it talks about loading, the loading is when the loading refers to the placement of the restoration. The faster the bone regrows, the faster the loading time. So I know today on TV you'll hear a lot of commercials about same-day implants. Yeah, they do that. That means that they put the implant in and they load them the same day. But it all just depends on the individual patient and the situation going on in the individual mouth. The biggest difference between the attachment of the periodontal tissue to an implant and a And a tooth is related to what? What's missing when we are placing an implant? Well, it's the PDL. So with implants, we lose our PDL, we lose that shock absorption, we lose that connective tissue attachment. The junctional epithelium is gone once a tooth is removed out of the socket and an implant is replaced. There's no longer a junctional epithelium. Note in this photo that there's no fiber attachment, very little attachment, just enough to form a new sulcus around the crown. So we do probe around implants, but we're really just probing around that area right underneath the crown up into the screw when we're talking about fiber attachment. So just notice in this picture the difference between a true tooth and a fixture. You might have to be able to identify something like this on an exam. So just what's the difference between having a natural tooth and an implant? Well, obviously it's that fiber attachment, it's the loss of the PDL ligament. So just be able to identify the differences between a tooth and an implant, and that there's no PDL, no cementum, and no Sharpie's fibers when we're talking about an implant, and the differences between a natural tooth and an implant. Patient selection for a dental implant can vary from office to office, but in general, we want somebody that's, in good health with healthy oral tissues, no medical factors, definitely someone that doesn't smoke is ideal, cooperative, emotionally stable. Going through an implant, you might lose a tooth and you might have to walk around without teeth in your mouth for a minute, and that might not be aesthetically pleasing for some people, so you have to talk about the effects of the whole treatment process. Definitely have to look at x-rays to see if there's enough bone that can support the fixture or the implant, and what the overall health of the patient is and what their needs. Is a single implant or partial or totally edentulous patient? So it just depends on the overall health of the patient, and is there enough bone there to support the type of loading that's going to be happening on the mandible or even in the maxilla. Quality of bone determines stability of the implant. The more dense, such as cortical bone, the more stable. Cancellous bone contributes less to the implant stability. Quantity is the shape. The more bone, the better. So just think back to the picture that I talked about earlier of that thin mandible. So if you look at this picture compared to, say, this picture, and look at the thinning of that mandible. So for the quantity that, we want a thicker bone. We want thicker bone. Which is the most important determinant of implant placement, the amount of bone or the quality of bone? Well, they're both equally important. Both the shape and the quality of bone must be considered, so it's just patient dependent. Again, you must also look at systemic conditions and social factors that could affect the stability of an implant. Just know that there are two types of implant placements, a two-stage, which is also known as the brain mark procedure, which is named after the doctor. And this stage is successful. Healing time is about 3 to 6 months. So with the two-stage, they insert the fixture, they allow the bone to osseointegrate, and then they cover it up, and then they have to uncover it, and then attach the abutment and put the restoration on top of it. So that's the two-stage. So they've cut it open, covered it up, let it heal, then they have to go back in, open up the gingiva again, and then put the abutment cap on, and then the restorative prosthesis. The one stage is where they place the fixture into the bone, and they leave a little healing cap on top. So there's no gingiva covering in a one-stage process. And you'll see this in clinic a lot. You'll see a little healing cap. It's pretty small. It looks like it's stainless steel, but it's not. It's a little healing cap, so you can see that one. So there's no second surgery to open the site. And then they'll put the abutment on, and then they can immediately put the crown on if it seems like loading is possible that day. The difference between the two, it just is a matter of opinion for the doctor. I have done some research where they say that the 2-stage is better because the whole fixture is covered up, so there's less room for bacteria to get in around that fixture. So it's completely covered and it's healing without the chance of bacteria getting involved. The 1-stage, again, you have that healing cap, so the bacteria can form around the healing cap if the patient isn't keeping their mouth clean during healing time. This is an example of a 2-stage procedure where the fixture was covered by the gingiva to begin the osseointegration process. And again, the theory behind this is that it keeps the bacteria out of the healing side as much as possible. So how do we know if an implant is successful? I mean, we have to check on our patients when they come in and do a certain amount of evaluating. And they say that, bone loss not exceeding 0.2 millimeters after the first year is considered successful. But the main thing that you're going to find and you're going to read in your textbook is that lack of mobility is the #1 factor in determining if an implant is successful. So how much mobility is acceptable with implants? Well, none. Healthy implants are osseointegrated and should not exhibit mobility. So here are some definitions that you definitely want to know. Peri-implant mucositis is a reversible inflammatory reaction in the tissues surrounding the implant. So what does that sound like to you guys? Does that sound like a little bit like gingivitis? So anytime that you hear reversible, think of mucositis. Peri-implant mucositis is equal to gingivitis in a natural tooth, if that will help you. Peri-implantitis is a term for inflammatory reactions that affect soft and hard tissue around the implant, leading to the loss of supporting bone. So what's the hard tissue around the implant? Well, that's the bone, so bone disease. So think of peri-implantitis as periodontitis. So peri-implant mucositis is like gingivitis. Peri-implantitis is like periodontitis. You need to know the similarities between the 4 different terms there. And of course, a failing implant refers to an implant that has lost osseointegration and is no longer an effective prosthetic anchor. Well, how do we know if it's failing? If it's mobile. So plaque biofilm is the primary factor in peri-implant mucositis, again, just like with gingivitis. We want to clean around the surfaces of our implants, just like we clean around our natural teeth. We want to do complete debridement, surface decontamination, and we just want to make sure that the implants are staying just as healthy and the gingival tissue around the implants are staying as healthy as our natural teeth. So the #1 goal of implant maintenance is to prevent infection without scratching or disturbing the fixture itself. Why do you think home care is so important, especially with a patient that has an implant? Well, if a patient has lost a tooth to begin with, it's probably a good chance it was lost due to periodontal disease, which puts the implant patient at greater risk for implant failure. So just think about that. And of course, I mean, if the patient lost their teeth due to an accident, we still want to take care of them, but just know that it's probably a good chance that, they lost the tooth to periodontal disease. When we're cleaning our implants, the book and a lot of people will tell you to use plastic instruments. We definitely have them in clinic. The only thing is that calculus is usually not very tenacious on an implant, but it does get some degree around there. But I just usually think that plastic instruments are just really useless, in my personal opinion. I don't recommend using ultrasonic scalers, even the ones that have the plastic sleeves with a fixture, just because it could scratch that fixture layer. The book, implies that we can polish with fine pumice or paste or tin oxide. I do have tin oxide in the clinic if you guys wanted to use that. It's just softer Jewelers use tin oxide to polish jewelry with. Your perio maintenance, or I'm sorry, your implant maintenance patients should be on, no more than a 6-month recare, just like regular standard natural teeth. You should take a radiograph of an implant to see if there's bone integration or to see if there is widening of bone. Again, it could lead to implant failure. Yeah, there's home care. There's lots of things that we can recommend to our patients. The Superfloss, I think, is the #1 thing. We'll see some pictures in a minute that show you some other dental aids to recommend. So why not an interdental brush with the metal, like a proxy brush that has metal going through it? Well, because it can scratch the fixture. The scratch fixture can lead to bacterial growth. The bacterial growth, again, can lead to the implantitis. So we just got to be really careful what we clean and poke around our implants with. That being said, okay, everything that we just learned about what not to do for implants. The individual practice, the individual doctor will expect you to clean around an implant with the tools that you have. That being said, it may be your standard curette, it may be a titanium instrument, and it may be an ultrasonic. I've had dentists tell me, get in there with an ultrasonic and clean around that tooth. Just know that the book stipulates that we need to practice caution around implants, but you will have different protocols in different offices. Just know that. Okay, don't be surprised if you go to work in an office and they don't have titanium or a gold-plated hand instrument. That being said, I'm going to leave it there. The most important consideration when debriding an implant is what? A, B, or C? They're all important. We want to remove the calculus, we want to remove the plaque, and we want to maintain the surface smoothness of the fixture itself. Okay? They're all important. The next 2 slides cover the NAU implant protocol that was developed a few years ago. Go ahead and read through these on your own. Just know that you're expected to probe around an implant, and again, we do have a setup of plastic instruments available for you. So if you know ahead of time your patient coming in has an implant, or you've seen the x-rays because you've looked ahead of time, go ahead and grab a packet of those plastic instruments and have them set up chair side, and go ahead and use that probe. In our clinic, that being said, we're not going to use an ultrasonic hand instrument or anything other than plastic on a dental implant. So go ahead and read through the next 2 slides at your own pace. Sort of like around dental crowns, most calculus around an implant is not tenaciously attached. So the implants, we want to remove the debris. Gentle strokes, light pressure. That being said, remove all of the plaque and calculus that you see around an implant. According to the textbook, acceptable instruments are made of plastic, resin, titanium, graphite, and gold tipped. The #1 unacceptable tool that you should ever be putting around an implant is stainless steel. This is textbook. That being said, the textbook answer is never use a stainless steel instrument on an implant. Again, this slide covers information found in textbooks regarding polishing implants. People use fluoridated toothpaste, rinses, etc. at home. Our Prophy paste has fluoride in it. It happens. I use Prophy paste on implants. Which is not an acceptable instrument for implant maintenance? Well, the textbook answer is stainless steel curettes. Stainless steel curettes. This photo is showing us some different options that you can use to clean around the fixtures. If you notice kind of in this first picture right here, there's some plaque, buildup, some calculus buildup right there possibly. And we can get in there and clean that with a couple different tools. This up here is yarn in the upper right-hand corner. They're using yarn. You could use Superfloss up there to clean around that to kind of break up the plaque and calculus. Down in the lower left-hand corner is kind of like a rubber cup, kind of like our occlusal brushes in clinic. We don't have these in our clinic. You may see these out in private practice, but it's a rubber kind of gum stimulator, if you will, to kind of clean up underneath the implant and the denture itself. And then right here on this slide is just showing you a little plastic curette. And you can definitely get in there and pick off your plaque and calculus with that. The proxy brush in the middle is blue, and if you notice that it's plastic on the inside, so you don't have to worry about it scratching the implant fixture itself because it doesn't have steel wire coming out of it, so it's plastic there. So if you have implant proxy brushes, great, use those. So these are all acceptable ways to clean around an implant. The next several slides are just pictures of different implant cases. So please go ahead and scroll through them at your leisure and look at the different implant placement, how they turned out, the differences in technique, and just think about how you would clean around them or how you would recommend treatment to your patients while you're looking at the individual photos. Okay, so to go back to the very first question that I posed at the beginning of this lecture is, what does a dental implant, a baby, a Porsche, and Meg Ryan all have in common? They're very high maintenance, so you have to be really careful and take care of them to keep them running, to keep them happy, to keep them healthy. So, all right. This is the end of the implant lecture. If you have any questions, go ahead and shoot me an email through BBLearn, and I'll be happy to answer any of your questions. Please go to week 13 in BBLearn and watch a few videos that I've posted. I have another example of a implant surgery and implant placement that shows osseointegration. It actually shows you a really good picture of the bone grafting material that they use, so I kind of thought that was awesome. There's also an opportunity for some extra credit over there under week 13 as well. I hope you all are doing great and hanging in there, and I hope to talk to you soon. Have a great day.